Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, a physiotherapist, the host of Paincast, and an executive member of the Pain Science Division. This episode is a student-led episode. I mentor physiotherapy students in the Pain Science Division Student Committee, taking them through the process of developing episodes on a topic of their interest. I will let Soheyl and Tess take over from here.
I'm Soheyl, a physiotherapy student from the University of Alberta.
And I'm Tess, a student physiotherapist from the University of Manitoba.
How can clinicians truly connect with patients to deliver pain education in an impactful way? How can modern pain science reach the public in unconventional ways outside the clinic? We had a very thought-provoking discussion with Bahram Jam.
Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of the individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. Hi, Bahram. We're very excited to have you on the podcast. How are you doing today?
Fantastic. I'm honored to be on Paincast.
Well, we're so excited to speak with you. Could you introduce who you are, what you do, and what a typical week looks like for you?
I'm Bahram Jam. I'm a physiotherapist for 33 years now. I graduated from University of Toronto, originally going back in the 80s. Then I did my master's in Australia, University of Queensland. Incredible experience. I did my doctorate in Andrews University in Michigan. And I've done all my level courses, became an FCAMPT and Mackenzie credentialed and Shirley Sarman program. And every course you can imagine, just because I had a dream that one day I'll be able to treat everyone in pain. Since I was a new grad, I was so anxious. And I believed once I'd learned the right techniques, then I'll be able to cure my patients. And that was what motivated me to continuously do courses. So when you say what a typical week looks like, I don't think I have a typical week. I've never owned a clinic. I mostly teach, so I travel a lot. Like last weekend, I was in Victoria, Vancouver Island. And this week, I'm in Toronto teaching. And every week is different for me. I do practice seeing patients at York University. I've worked there for 26 years now at Athletes Care. And it's primarily chronic pain. And I also go one day a week at the SickKids hospital where I run a pediatric chronic pain program. So that's my typical thing: teaching, spending time with my family, hiking, and seeing patients. And that's when, on those days, I have that on the whole time. Sometimes I put this on for the grown-ups too, if I think it makes them laugh.
That's great. Could you tell the audience what you just showed us and put on your nose?
What did I show you? That's the nose thing to make people laugh.
Okay, awesome.
So I greet the kids with it, mostly when I'm at SickKids, because the kids I see with chronic pain, they've seen so many doctors and therapists and MRIs and imaging. They're horrified of coming and seeing another therapist. So when they see me, I want to make sure they don't feel like they're in another medical environment. So immediately I greet them with this. They say, "Who's this weirdo?" And I do lots of magic tricks with them too. I have all kinds of tricks up my sleeve. And then suddenly they go, "What's happening?" So my primary job is to make every patient I see feel like they're not broken. Let's just say that. And they're not here for me to fix them.
I love that summary and boiling down to those two principles. So you mentioned that your dream and your passion and your whole career trajectory was towards healing, curing your patients from pain. So could you tell us more about why you're so passionate about chronic pain and talking about pain education?
Yeah. Many people say they got into chronic pain because they've experienced pain in their past or the family member has. And I've been blessed, fortunate. I've never experienced chronic pain. I've had acute pain, stubbing my toe. I've had a couple of surgeries and stuff like that. I can't say it's because of a personal thing. It's truly because when I couldn't help my patients get better, I felt like I failed them. And it was like a disappointment in me, especially as a new grad. And new grad, I mean, the first 10 years of my graduation, I consider a new grad. And I felt like a failure because I so desperately wanted to help them. And I couldn't. And I said, I must not have enough knowledge to be able to fix them. If I only could feel C5-6 left rotation hypomobility better, then I could fix C5-6, that which was their problem. If I could feel L5-S1 facet joint blocked, then I could manipulate. If I could only manipulate cuboid in the right directions, then I could help their foot pain. And then on and on. So I focused so much on orthopedics. And then I guess it's been 2 decades now that I realized the solution is not in their physical body for my patients. It was not at all everything that I had learned.
You mentioned that biomechanical and just body-focused approach didn't work for you in addressing the pain of chronic pain patients. And in school, we're learning about other methods to address chronic pain, such as pain neuroscience education. And we're curious to hear more about what is to you pain education.
Sure. At first, pain education was Explain Pain, which is the ultimate book written by Lorimer Moseley, David Butler, almost 20 years ago now. And it was the gurus with the greatest respect for them. It's like you sit for 1 hour lecture, and for 6 weeks, you listen to 1 hour lecture on pain and learn about synapses and substance P and calcium ion channels and all that stuff. I wrote a book on it myself, The Pain Truth. I made my website from almost 20 years ago, thepaintruth.org, into offer pain education. And as the years have gone by, I realized that is not pain education. Pain education only comes when you're verbally one-on-one casually talking to the patient. It's not seeing in a video, and it's not written in a book, and it only comes when you make the person immerse in it and make them actually experience the thing that you're trying to teach them. The analogy I give is, if somebody wanted to learn to swim, could they read a book on swimming written by Michael Phelps, like written by, remember, Lorimer Moseley, David Butler, the gurus, and learn to swim? No. What if they saw the video? It's the best video in the world, created exactly how to do your strokes and swim. Would you learn to swim by video? No, it's no way. You can watch it. You can get familiar with swimming, but there's no way you can learn to swim. The only way is to get it into the pool. There is no alternative way. And so what I've learned is I no longer lecture. It's not about the videos they watch. It's not about the books you read. There's nothing wrong with reading them, but they're certainly not enough. You have to get the patients to get their foot into the pool and eventually float and swim.
That's a really good way of describing that. I really love how you nailed that. You can't really create anything that's concrete that you can follow step by step. It's something that you need to learn by experience and work with the patients and figure out what works for them, not just hand them some resource for them to work through.
It doesn't work. It works to some degree, but the people where it worked, pain education, is when they actually applied it to their life. And when it doesn't work, we say, well, it was a bad patient. They didn't learn it. No, it's just, and pain science education has very limited evidence on its benefit. Yes, it works a little bit, just like exercise works a little bit, just like manual therapy works a little bit.
Always using it as an adjunct to everything and treating them holistically, I would summarize it as.
I'm going to say pain education is not an adjunct. It's the treatment if you actually give people the opportunity to be able to apply it into real life. And that's where the challenge comes in.
Yeah, that makes sense. Now, I'm curious, what are some of the first pain science concepts that you typically first introduce to patients? And do you introduce them at a specific time, or when do you do that?
Yeah, I don't want to be a cop-out and just say this thing. That's so cliche, but it's actually true. Every patient is unique. You can't have two people that are the same. So I honestly don't have a typical thing that I say to my patients. I would say the most common thing that I start off with, I try to explain the concept of central sensitization to them, because these are patients who've been to multiple physios, chiros, osteopath, and I'm just another physio they see. So I have to have a different approach on an explanation for their pain, or else I'm no different. But to explain central sensitization, the word is just, what does that mean? And some authors have disagreed with the term central sensitization. Like Lorimer Moseley calls it pain system sensitivity. Other people call it a psychogenic pain, doctors. Well, I detest that term because it makes people think the pain is in your head, psychogenic pain. And then there is functional disorders, which means, the pain is not structural, it's functional and all that stuff. There's non-organic pain, which is Gordon Waddell coined that in 1983. Non-organic pain also implies like it's not real. But the term that I like the most, and I know most physios aren't aware of it, is the concept of primary versus secondary pain. And that's what I teach my patients. And when they learn that, a light bulb I see really goes off. Now, the way I explain it is that there are two types of pain. Secondary pain, when the pain is due to an explainable cause, such as a structure that's damaged, injured, or affecting the body causing pain. And I play trivia with them. Play along with me, all right? So I say, if I bang my thumb with a hammer, what kind of pain is it? Do you think primary or secondary? The answer is it's secondary, because it's secondary to me banging my thumb with a hammer. If I never banged my thumb with a hammer, I wouldn't have the pain. Make sense? I intentionally want you to play along with it. So the secondary to a bruised thumb, right? To a bruised skin, tendon, bone, nail. My nail got black, it's secondary. If I play basketball, I twist my ankle. What kind of pain is it? Primary or secondary?
I guess secondary.
Secondary to a sprained ankle. If I never sprained my ankle, I wouldn't have pain. Secondary to ligament injury. My grandmother fell down the stairs, broke her hip. What kind of pain?
Secondary again?
You're getting the point. I got a chest infection or strep throat because of an infection, and it's really painful. What kind of pain?
Secondary.
Secondary again.
Secondary to an infection. All right. Rheumatoid arthritis. My hands are swollen up. Autoimmune disorders. My fingers are all swollen up. What kind of pain?
Secondary.
Secondary to an autoimmune disorder. My joints are inflamed. Right. Now, what about this? The worst pain, cancer from a tumor. What kind of pain? It's secondary to a tumor. If I didn't have a tumor, I would not have the pain. And people get this. Okay, secondary pain, you have explainable structure for. And I tell them, modern medicine is incredible at detecting and treating secondary pain. Incredible at it. Like you strain your muscle, physio can detect the strained muscle, and we treat it with some strengthening, stretching, massage, and rehab, and people are back to playing football again. You tear your ankle ligament, we brace you for a while, give you exercises, and you're back to running again. You get an infection, doctors quite easily diagnose an infection. Take some different courses of antibiotics, boom, solves it. Rheumatoid arthritis, pretty easy to identify. Blood work, testing, they say, yep, you got a rheumatological disorder. It's not easily curable, but they can manage it with certain medications and immune suppressants and even get into steroids. And even, again, hip fractures, guess what? Leave them alone. The bone heals on its own. You don't even have to do anything for the body to heal itself. And it's easily detectable fractures. And worst case scenario, doctors, surgeons put pins and plates in there, and people 3 months later are back to playing golf and they're good again. And worst pain, cancer, as we said, most often easily detectable. Even early detection is getting better and better. And majority of people with cancer get better. That is the fact. Why? They know in medicine, incredible achievements, this much chemotherapy, this much radiation, this surgery, and people recover amazingly with cancer. So you can see modern medicine, when it comes to secondary pain, incredible. And I tell them, however, you don't have secondary pain. You're experiencing primary pain. And the reason I love the word primary, it doesn't imply that the pain is not real, or in fact, it's so real, it's primary. And then they say, well, what's the example of primary pain? I said, well, headaches. I said, what do you mean headaches? I mean, headaches is probably the number one cause of pain people experience in the world. But if you took CT scans, brain imaging, x-rays of people's heads, would you be able to tell if somebody has a headache or not?
No.
No. But is the pain real in a headache?
For sure, yeah.
It is real. But is it caused by a structure? The typical headache that's identifiable and treatable. The answer is most often 99% no, meaning that sure, Tylenol and Advil help, but they're not changing its structure. So what I say about headaches is that headaches can be triggered, for example, your mother-in-law visiting or work stress or whatever. Now, can that be seen on imaging or blood work?
No.
No.
But it's something that you experience.
Something that you experience, and the headache is real. Now, the worst type of headache is a migraine, debilitating headaches. And I ask them, have you ever had migraines? Some say no, some say yes. Now I say, is migraine headaches that experience where the pain is excruciating, is the pain real? Yes, it is. But can you tell by imaging if somebody has migraine or not? Nope. Our experience says, nope, you can't. Is there a way we know in modern medicine to cure migraines? Nope, we don't. So migraine is pretty much primary pain. We don't know how to differentiate somebody who experiences migraine who doesn't. Now, what triggers migraines, for example? We know that anything that's a potential threat to our well-being can trigger a migraine in people. And people have various sensitivities in the migraine. For example, some bright light can trigger migraine for some. Loud noise can trigger a migraine for some. A smell of a perfume can trigger a migraine for some. Mother-in-law visiting can trigger a migraine in some. Not sleeping for a couple of nights can trigger a migraine for some. Being hungry can trigger a migraine for some. Hormonal changes can trigger a migraine for some. So you can see, is it a brain disease then? No, it's not. It's anything that's a threat to the nervous system and any one of the sensations I've experienced. And so headaches can be caused secondary, like if you have meningitis, easily diagnosed and treated potentially. A stroke, diagnosed. Concussion, hemorrhage in the brain, diagnosed. Brain tumor can be diagnosed. And those are secondary causes of headaches. Majority of people don't have that.
Yeah, that's a really good description. I think we should stay with that idea for a little bit longer. I want to talk about how some of the messaging I've seen you use in some of your online resources is that pain is in the brain. Are these analogies that you use about migraines, is this how you reinforce to patients that, yes, the pain is in your brain, but the pain is also real?
Yes, for years I've used that, but I'm moving away even from that as my belief system changes, because I don't think pain is in the brain anymore. I think that's too narrow thinking also, where we say all pain comes from the brain. Pain is in every cell in our body. And its pain can be experienced, originate from the gut, for all as we know, originates from an olfactory system. So I move away from just blaming the brain also, because again, we're doing one structure. That's the cause of everything.
Right.
It's the entire human body, nervous system, immune system, vascular system that is actually responsible for helping us sense if we're in danger or not.
That's a really good way to put it. I wanted to know, what are some of the methods or approaches that you use for pain education? I've seen you advocate for doing reflection exercises or writing a letter to your own pain, goal setting, much more. Can you tell us what approaches you use at this point in time? And can you help the audience visualize how these are incorporated into your sessions?
I'm going to correct you. I don't do anything anymore to fix my patient's pain or their chronic pain or try to resolve it. I've moved away from that mindset. The reason I can work 11, 12-hour days, seeing only chronic pain patients, and at the end of my day, I feel fully rejuvenated and not tired, not burnt out in any shape or form. And I've been a physio for 33 years. So theoretically, I should be retiring, but I have no desire to retire because I absolutely love what I do. And it doesn't matter if I work how many hours a day seeing chronic pain. And the reason is I don't try to fix my patients or get rid of their pain. I know that's a mindset that's completely foreign to healthcare professionals. But my focus is not to reduce pain. My focus is to get them back to their life, get them back to their function. And if I had to say what is my primary job, is not to reduce pain, is to reduce or eliminate fear. Fear is their highest predictor of pain persistence. Nothing else.
Is this the art of communication that you kind of use? I've heard you say things that are quite humorous at times and might make the patient laugh. Is humor something that you use in some of your communication methods?
Absolutely. At least make a patient smile. Well, I try to match their mood. I'm not going to start laughing if I see them in a somber mood and they're very sad and depressed and stuff. I would say the highest predictor of outcome for any patient, of chronic pain especially, is the therapeutic alliance. We know that. Basically means how much the patient likes you, how much the patient trusts you, how much the patient believes you, how much the patient believes that you have their best interest in mind, right? And so those factors are the highest predictor of recovery. If I don't have that, my word doesn't mean anything. No matter if I provide them the best therapeutic advice and pain education, it's all meaningless. And I find one of the best ways to build that therapeutic alliance is through humor. Now, when I say humor, it's not like I tell a joke. It's not that. I would say one of the best courses I ever did in my life, I went to Second City and did a year of improv course. And that's what I do in my teaching. My teaching is all about improv, where you say yes and you learn how to communicate with people. You learn how to take what somebody else says and make it more lighthearted or make it so you empower that person and never negate somebody that says something. It's all about validating. If I had to say what's my number one treatment for patients to reduce their fear or build therapeutic alliance is to validate. How do you validate someone? Well, that is a skill.
That's amazing. And I'm so interested to hear more about, what you learned from theater and that through improv and validating that you're able to reinforce this therapeutic relationship that is so important. Before we touch upon more about theater, because it is also a part of your career and your creative projects, you brought up the concept of reducing fear. And I came across in some of your work, you talked about the DIMS and SIMS framework that I believe Mosley introduced, and it has a big role in discussing the danger and safety messaging with your patients. So I know you mentioned some of your approaches have changed, but could you tell us a little bit more about DIMS and SIMS, what they mean, and how you might use that concept still?
Sure. I've moved away from the words DIMS and SIMS, not that they're wrong or inaccurate. I personally have, but basically every patient I say, the moment you wake up in the morning, the body has to decide, the nervous system, are you sensing more in danger or are you sensing more in safety? If the nervous system senses it's more in danger, it'll be on high alert. And if it senses more in safety, it'll be on low alert. So if it senses it's in danger overall from the moment you wake up, your nervous system will overreact to every normal sensation. The analogy is, let's pretend you're watching a horror film. I don't like horror films, by the way, but some people watch horror films. And you're watching it. You're in the edge of your seat watching a horror film. Somebody's head's getting chopped off, whatever, in a dark room, and the door is creaky, blah, blah, thunderstorm in the background. And you'll go, oh, and your partner or friend comes from behind and taps you gently on the shoulder. You go, oh, you'll go like this. Is the tap the problem? No, you reacted to the tap, which inherently it's safe. But your nervous system, because of the state you were in, sensed that any even non-threatening sensation is interpreted as danger. So some people are watching a horror movie 24/7 of their life. And our job is to say, let's try to change this channel a little bit. Let's focus on things that make you feel safe. And the number one thing that makes people feel threatened to their nervous system is pain itself. And so if I had to say, how do I change people's fear, is to reduce the fear of pain. And how is that done? By changing the relationship with pain. And that's what I tried to do in the musical that maybe we'll get a chance to talk about. So the relationship with pain is what predicts how well they're going to get better or not. It's not about changing pain. We obsess over eradicating pain, fixing pain, injecting it. If you want to get rid of pain, just take an opioid. Opioids cured my pain, said no one ever in history. Because that resolves pain, but it's not resolving it because you never change your relationship with pain. In fact, it makes the relationship with pain worse. It makes it something that you have to escape, something that's dangerous.
Right. So you mentioned you moved away from the DIMS and SIMS and the danger in me, safety in me. I remember seeing a questionnaire where you sort of outlined, what tips the scale towards danger and what tips the scale towards safety. So when you're trying to have a conversation with patients and figuring out where they might be on that scale, do you do it through a questionnaire where they can write it and where they see perhaps how much is on the danger side versus the safety side? Or do you do that more conversationally to find that out from them?
No, I call it a danger scale and a safety scale. I just don't call it DIMS and SIMS. No, that questionnaire is still on my website, on thepaintruth.org, under questionnaire. 10 questions that determine how safe they feel, 10 questions, how much danger they feel. And of course, people with chronic pain, all of them pretty much, their danger score is much higher than the safety score. And as long as that's the case, anyone who taps them on the shoulder, they'll jump. Or when they bend forward, they'll scream. When they turn their neck, they'll have pain. When they sleep at night, they'll wake up in the middle of the night with pain. They'll wake up in the morning with pain. They'll have pain with walking. It's not about walking. It's not about sitting. It's not about the tap on the shoulder. It's all about how it's interpreted based on the physiological context that they're in right now.
Okay, yeah, that makes sense. Do you use it in your practice, or is this a questionnaire you have them do more on their own, or do you use it as part of perhaps an intake form or as an outcome measure where they would redo the same questionnaire later on? What's your approach to this questionnaire once you get that information? What are the next steps?
Yeah, I have 4 outcome measures that I use for my patients, well, 5 of them, because I'm a fan of outcome measures. Because when it comes to chronic pain, how do you know if somebody's better? Range of motion, strength? No. My favorite thing is patient-led goals. What another term uses patient-specific functional scale, where I ask them, name 3 activities you wish to do again. This is your wish list. Name three things. I want to be able to do my full yoga class. I want to be able to play with my grandchild. I want to be able to golf again, whatever they say, right? And I say 0%, you can't do it at all. 100%, you're fully satisfied with your current ability to do it. They say yoga, I can only do half the class, so 50%. Playing with my grandkids, I'm 70%. Golf, 0%. I haven't played in 3 years. And then I average that, and that's my outcome measure number one. Because to me, that's the most important outcome measure, the patient's own goals. Number two that I use is a pain disability index, PDI. Valid questions, 7 of them, activities of daily living, sleep, blah, blah. Generic, doesn't matter if you have TMJ pain or back pain or fibromyalgia. I find the pain disability index to be, and this is all on my website and outcomes are there. They're easily added up. My website adds up the score. You don't even have to add up anything. The other one is pain self-efficacy questionnaire. And it's 4 questions because the perception of how much pain is affecting their life strongly predicts the amount of disability and chronicity, pain self-efficacy. The other one I use is the CSI on some people, central sensitization inventory, which to determine how centrally sensitized they are. It's 25 questions. And for example, do I clench my teeth? Do I get migraines? Do I have sensitivity to loud noises? Do I have body aches? Blah, 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 how well my sleep is. And if they score 40 or more, they're considered to have central sensitization. If they score like 60 or more, they're highly sensitized. And I've had patients who've been over 70 or 80, and I can't treat them because they're just way beyond my scope of practice. These are people I've had who've had 2 suicidal attempts and, they're on opioids and PTSD. I'm unfortunately beyond my scope of physiotherapy. So if they're between 40 and 60, I can handle them. And then the fourth thing is that I call it nervous system sensitivity scale. And that's where I measure the amount of danger they're in, the amount of safety they're in. There are 10 questions on safety. For example, how good's your sleep? 0 is not well at all. 10 is excellent, right? Sleep is one of them. How much time you spend outdoors in nature? 0, not at all. 10, I spend every day an hour.
Yeah, so that's great to hear about that you have different outcome measure tools, some of them that are the more traditional, and then the one that you mentioned about the last one. Is this one that you've developed yourself, or is it something that existed out there prior?
No, I've developed it myself. It's not really an outcome measure. It's exactly what you said. It helps me guide where we're going to focus on the patient. I say pick 3 of the top safety things that you want to address that are most important to you. For example, stress and anger about the pain. Or I want to address my sense of self-acceptance, right? So I make them pick 3 from the danger side they want to address, 3 from the safety side they want to address. So my treatment is based on what they want to do. That's why every patient is unique. If they have a sense of loneliness, for example, right? Lack of social connection is a strong predictor of chronic pain. No amount of pain education is going to help that. Then I got to help them join a choir, join an exercise class, a yoga group class, something that makes them feel connected as a human being. Most people with chronic pain are alone. No medication will solve that. No manual therapy will solve that. No massage will solve that. No soft tissue release acupuncture will solve that.
That's a really good way to summarize all of that. And I think you provided some really good tools for any clinicians that are maybe listening to potentially incorporate in their practice. Maybe they don't have to use all 5 outcome measures, but these are always tools that you can use whenever you feel like it would work as a clinician. So that was a really excellent discussion of the specific methods for treating patients with pain. On the same note, I wanted to know, do these outcome measures also serve as a way to validate patients and validate their pain?
They do help them understand it, understand why they're experiencing pain. Pretty much every patient that comes to me thinks their pain is from their physical body because that's what they've been told for years by their doctors, by their osteopath, by their chiropractor, by their physio. And we're obsessed with fixing the physical body when it comes to chronic pain. And it's just not right. Because if it's structure, if it's secondary pain, guess what? Secondary pain gets better. We don't even have to do anything to patients and people get better with secondary pain. Torn muscles, ligaments, post-op, people just get better. Physio just accelerates it and makes them, get better, perhaps higher functional level, which I'm all for. But if we left people alone, they'd be fine. Even kidney stones, secondary pain, but it passes unless you need surgery. Pain is severe.
I really like how you're framing it in a positive way. It's really enlightening, I think.
Secondary pain gets better, but when they don't, it's obviously primary pain. Like a year later after your car accident, whiplash, from a 20-kilometer-an-hour accident, you're still in pain a year later. That's primary. I mean, the pain itself is what's causing the pain.
That makes sense. How does validating patients help people change their relationship with pain?
If I had to say the single greatest thing we can do to make our patients feel safe, raise the safety score, is to validate them. What does validating mean? It means show them that they've been heard. Now, what does that mean when you heard? Most times, patients feel they haven't been heard, either because they got 5-minute doctor's visits or they've gone to the physio, and they've been trying to be fixed and it hasn't worked. They say, obviously, I haven't expressed my pain well enough because people aren't able to fix me. And now, even if they go to the most wonderful doctor and the doctor assures them, there's nothing wrong with you, you're going to get better. Doctor says, well, I did my job. I assured my patients, because doctors know assuring patients is one of the best things they can do for patients. The challenge is there's a very fine line between a patient feeling assured versus feeling dismissed. Fine line. And if the moment the doctor may say, or the therapist may say, well, I assured the patient, but the patient may go away most often feeling they were dismissed. Well, there's nothing wrong with you. For example, it's all in your head and you're going to get better, but I'm not better. You're going to get better with 6 weeks, but I didn't get better. So it's like I got dismissed. And the moment a patient senses they're dismissed, it's impossible for them to get better. Because how can you get better if you have to prove your pain? Impossible. Because then they're put in a position where they have to prove their pain to a healthcare provider, where they have to prove their pain to an insurance adjuster, where they have to prove their pain to workman's compensation, where they have to prove their pain to their partner, their spouse. For example, the partner may say, oh, there's nothing wrong with your back. You're just too lazy to cut the grass. You're too lazy to go back to work. And if it's a wife telling that to a husband, the husband's pain inevitably increases because the brain says, they don't believe me. The brain says, hey, let's increase the pain intensity so they'll believe me, which doesn't make sense because pain is invisible. Or if the husband tells the woman, you know what, your neck pain is really not that bad. You're just too lazy to cook. That would really cause anger. And what the brain does, it increases the person's pain in order to prove to their partner that they are really in pain, which doesn't make sense because they're the only one that will experience it. Now, it doesn't have to be partner. Their pain increases so the doctor will believe them, so the insurance company will believe them. And is the pain real? Of course it is. And it's because they didn't feel validated. Now, if a partner doesn't believe them, as a physio, do I have any hope of helping them? I'm going to say, yes, I do. Even if they have one person that believes them, they sense that they didn't feel dismissed. You can make people better. Where at least they're with me, they don't feel like they have to prove their pain to anyone because I validate them.
That leads very well into our next question, talking more about contextual factors and making sure people feel validated, but also everything else going on with them. So what I wanted to ask is, with so much going on in the world these days, for example, there's the unrest in Iran, which is deeply close to both of us as Iranians. How do you approach treating someone who is affected by a situation like that, who might be struggling not only with maybe a physical injury, but they're dealing with a lot of mental load and a lot of other things that are going on, not just their injury or whatever they're dealing with?
Excellent question. Just so you know, I'm from Iran. I speak Farsi, Persian. And so a good quarter of my patients are Iranian, just because, word of mouth, and I speak Persian. And of course, with the current stresses they feel in Iran, but it doesn't matter. You can be from Ukraine and feel the stress in Ukraine. You can be Jewish. A quarter of my patients are Jewish, and they have the same stresses of their country. You could live in Canada and be indigenous and the same stresses in life. You can be LGBT community and feel the same sense of oppression and sense of injustice. It exists in every community. And my job is to say that stress is a factor in maintaining pain. And they acknowledge that. I give them movie theater now, watching a horror film. If you watch a horror film, somebody gently taps you on the shoulder, you'll jump. It's not about the tap. It's because the context that you got tapped was in a context of danger, something that was threatening your well-being. The threat to your well-being could be anger, stress, grief. A loved one has passed away, right? So it could be anything that does it. So, and I don't tell my patients, you need to reduce your stress in your life. Why? Because if I tell patients you need to reduce your stress, that actually increases your stress. How am I going to reduce my stress? I still got to go to work. How am I going to reduce my stress? I'm going through a divorce right now, so I'm never going to get better. How am I going to reduce my stress, when there's all this thing going on in the Middle East? and the war going on. So it's not about reducing or eliminating stress. I think that's a myth also, because then people believe unless my stress was gone, then I'm not going to get better. And I don't want my patients to believe that, because stress is part of life, whether we like it or not. And I don't want them to feel trapped unless their stress goes away, that their pain will go away. So what I tell them is needed to recover from pain is not the reduction or elimination of stress, just the awareness that stress is causing their pain. Just the awareness and moving away that it's a physical body is feeling the symptoms, but it's not the cause. And that's all that's needed. And that's one less stress in their life, their physical ailment, because they fear that their body is broken. I can't change world situations, but I can certainly change how they feel about themselves, because they feel they can't control external factors. You know, you said Iran, we can't control any of that stuff. And a quote I use frequently is, we suffer when we try to control things we cannot control. So what's the only thing we can potentially control? How we respond to things, including how we respond to pain.
Yeah, lots of food for thought in the last thing you described, in that sense of control and trying to control sometimes everything in our life. And when there's so much out of our control as well, the fact that even though these stressors exist, these stressors can be very oppressive, that they're not necessarily going to disappear or go away, because people's lives are complex and stressful, and that's normal, but that yet they can still recover from their pain despite all of that. Something else I wanted to touch upon, and you talked about it a little bit, and about validating the patient and their pain experience, and how much at times they do get dismissed through their journey through the healthcare system, with perhaps some practitioners that are well-meaning or perhaps frustrated because, you know, they don't know how to approach this for the person. When I was listening to some of your body of creative works, I came across one of your spoken word poems called Fix My Addiction. And a part of it really struck me and caught my attention. It says, unless you're willing to understand my whole life situation, unless you can address my sense of social isolation, unless you can appreciate my justified sense of victimization, please don't you dare to even try to fix my addiction. When I heard those words, I was wondering if these words are inspired by your experience trying to help a person who is very angry and perhaps jaded from a poor journey through the healthcare system and is left feeling hopeless. How do you approach treating a patient who has had that journey and that experience and carries that anger?
Yeah, most patients who come and see me, they say, are you a physiotherapist? I don't feel like I'm in physiotherapy. I'm in psychotherapy. Before I answer that question, I want to clear up something. I'm not a psychologist. I'm not a psychotherapy, nor do I practice psychology or psychotherapy. Meaning that people say, isn't this outside of our scope of practice? I say, absolutely not. I do not diagnose or claim to treat depression. I do not claim to treat anxiety. I do not claim to treat bipolar disorder, schizophrenia, PTSD. We're not qualified to treat those things, and I 100% acknowledge that. What I am fully qualified to diagnose and address is fear. Fear of movement, fear of physical activity, fear of getting back to life. And why are people afraid of going back to life and thing? Because of their past histories of what they've experienced. And so I can't change people's past life experiences, whatever trauma they've had. And that verse that you read, unless you're willing to understand my entire life situation, please don't fix my addiction, basically comes from Gabor Mate, because all the things that he's worked with addiction. And every addiction is an attempt to escape pain. And the question is, the quote is, don't ask why the addiction, ask why the pain. And I've written a whole book on this, is chronic pain and addiction. I know it was controversial. I presented it at one of the conferences before. I got a lot of rejection for it because people disagreed with me. I don't care if they disagree. I believe it's an addiction, pain. Whether it's to feel heard, an attempt to feel understood, an attempt to feel pain so they can escape it, whatever their mode of addiction could be. You escape it through alcohol, for example. We consider alcohol to be the addiction. No, the alcohol is the method they use to escape the pain that they're addicted to, that their body constantly is their default mode. Drugs are a default mode you take to escape the pain that you're addicted to. I'm going to make it easier to understand. Coffee. People drink coffee. I'm not a coffee drinker, but my wife drinks coffee. Nothing against coffee. Enjoy your coffee, whatever number of cups you drink, love it, enjoy it. But if people who actually drink coffee every day, if they don't drink coffee a couple of days, are you a coffee drinker, Tess?
Yes, I am. Yeah.
Have you gone 2-3 days not drinking coffee?
I have.
And?
I have experienced headaches.
Okay, you experience headaches. So why do you experience headaches? It's a pain.
Mhm.
Let's just call it a pain. Now you would say, well, that means, or anxiety about jitters, not having it. It's a discomfort in your body that you sense. So the solution is to grab another cup of coffee and drink it. And you say, see, I drank my coffee and it cured my pain. The coffee did not cure my pain. The lack of coffee is what caused the pain in the first place. If you had never drank coffee in the first place, you would have never had the pain to begin with. The coffee did not fix your pain. People go for massage, physio, osteopath, chiropractor, take medications, and they believe those are fixing their pain temporarily. When they don't go there and their pain comes back, they see, then no, their analogy is, then they fix my pain. They didn't. They're actually causing your pain because of your addiction to get pain relief. People are addicted to finding relief in their body. It's almost the body says, I want pain so I can get that sense of relief, even if it's temporary.
So you're really into an active treatment, not allowing the person to continue with this belief that passive treatment is going to fix them. Do you find it challenging to have their mind shift around that the previous treatments they may have received that were passive, that they felt perhaps was helping them, but yet it didn't cure them of their pain? How do you get them to buy into your approach and one that's fundamentally different? Like people ask you, like, are you, it doesn't feel like a physio appointment. What's that process like? And have you had instances where people really didn't want to buy into that approach?
Absolutely. To answer your last question, are there people that don't buy into the approach? 100%. Can you please everyone all the time? Absolutely not. Even if I'm able to help a fraction of my patients with chronic pain, that's more than what they do at pain clinics with injections, right? Or with opioids, far more than that. The buy-in that I do is, first thing that has to be there before I even start this conversation, I need therapeutic alliance. If I start with, oh, there's nothing wrong with you, it's primary pain, you're not going to get better with any physical exercises or physical treatments to your body or medications, you're only going to get better if you change your attitude and your mindset, that's what's going to get you better, focus on function, they'll walk out. They say, you're an idiot, I'm never coming back to see you again. If you don't have that therapeutic alliance with them. How do you build therapeutic alliance? Well, that's individualized, unique, whether I'm seeing a 7-year-old or whether I'm seeing a 70-year-old. Generally, it's by somewhat doing this and being lighthearted, but yet taking them seriously, of course. But I like to quote Albert Einstein a lot. I tell him, Albert Einstein says, the definition of insanity is doing the same thing again and again, but expecting different results. You've tried other approaches that have tried to fix you. But why not try a different approach that doesn't attempt to fix you? And this approach that I'm offering costs nothing. And the beauty of it, you don't actually have to do anything. And the other beauty of it has zero side effects. And just so you know, and I have patients who come to me at their last wit's end. They've tried everything. They heard, got to see Bahram Jam, and they see me. They're ODSP. They've been on disability for many years. They don't have any money, but they put some money together to come to see me for one session, thinking in one session, I'm going to cure them and crack them or something to get them better. And I do no such thing, I tell them. But one thing that really connects with them, I tell them, my only motivation is to help you. If you don't have any coverage for physiotherapy, just so you know, your listeners can know too, I see a significant number of my patients pro bono because I don't really work for money anymore. Just because I don't have to. But I find even when I work pro bono for people, it has a 50% dropout rate. I'd rather charge if I can, because when you charge people, the more likely it has some value. But some people that do pro bono and they come and they do the program and they get better, it's like the greatest feeling you can. I do it for selfish reason because it makes me feel good. Because I say, if I don't see you, I don't know who else. I don't know any pain clinic that will do this for you. Again, my answer to your question was Albert Einstein. The definition of insanity is doing the same thing. And every time you try to fix your body and it fails, you're actually further perpetuating the chronic pain because your body even feels more broken. What if we tried an approach where you no longer felt broken And the only way that's going to happen is when you truly believe that you don't need to fix yourself.
Mm-hmm.
And nobody needs to fix you. And when you truly believe that you do not need to get fixed, that's when healing happens.
That is very powerful and such a refreshing approach that so many patients have never been told so bluntly and clearly. Is this a conversation that you have usually on the first session with somebody, or on the first session do you have more of a, traditional physiotherapy approach with more touching and checking out structures, and then segue into more of a pain education and having that conversation?
Yeah, I don't want to cop out of the answer, but the answer is it depends on the patient. So some days, some patients, I immediately jump into it. I feel like I got good therapeutic alliance. They already came to me primed because their friend told them, oh, you got to see Bahram Jam, he cured my pain. So they're already primed. If it's a patient that doesn't really know me, they were forced to come and see me, I have to play along. If they say, I want ultrasound for my shoulder, I'll pick the ultrasound machine out. And I don't know how to plug it in exactly or how to turn it on, but I'll pretend I know how to use it. I give them what they want.
Yeah.
So I go to that extreme, give them what they want at first, and I touch them, do the manual therapy. But if somebody says, I feel like I need to be manipulated, crack them because my joint is out, my pelvis is out, need to be put back in. And I've seen osteopath chiro who tried to put back in, but it didn't work. I won't do that though.
Okay. I think this gives the audience a better understanding of your approach and how pain education isn't something you can just, sit down and start telling a person about, that it has to be weaved in and adapted depending on the person and their personality and their expectation. With the time we have on the podcast, something else we wanted to really spend some time chatting with you about is Pain the Musical. And for those in the audience who aren't familiar with the musical that Bahram, you produced and wrote, can you briefly introduce what it is about?
Sure. I'm a musical junkie. Like all my life, I've loved musicals. If you can say Phantom of the Opera, Les Mis, the popular ones, and even all the non-so-popular ones. And I was in a band for 10 years. During high school, during all my university years, I played guitar and sang, wrote songs. Even during physio schools, I was doing shows in all the downtown clubs in Toronto, Elmo Combo and Opera House. So I used to have long hair, I was a rock star. So anyways, at some point, the band fell apart, continued with my physio career. And it was during COVID that I said, now what? I wasn't seeing patients. I said, my dream was always to write a musical. But now I got time because I wasn't teaching anymore. I wasn't seeing patients. I said, what could I write about in a musical? What do I know the most about? Pain. So I'm going to write a musical on pain. And so I started the project. And many of the songs I wrote 40 years ago when I was in my late teens and in my 20s. And so believe it or not, even then I wrote about pain for some reason. Then gradually I got a playwright, I got a musical director, because this is not a one-person show. I have to give thanks to Martin Julian, who's the playwright, because the first play I wrote, I even took a course on playwriting during COVID. I realized can't be a physio and just do playwright on the side. The play that I had written originally was a really crappy play. It was miserable. It was on chronic pain. And basically when I got the playwright, he goes, you can't do a miserable show. People won't come. And you leave people feeling. I said, but I wanted inspirational. I said, it has to have comedy in it. So right now my musical is mostly comedy. And the vision that I had was I personified pain as a character because I said, what if pain could speak? What would it say? That was always what I told my patients. So I personified pain. The gist of it is pain comes out, people thinking is the villain, is the bad guy that we need to destroy. By the end of the play, you realize pain is the good guy. Right? He's not to be destroyed. He's the one that wants to be listened to just as much as we want to be listened to. And if we just approach pain not from a place of resentment, anger, and hostility, but we approach it from compassion and understanding and love even, the whole relationship dynamic changes and chronic pain actually disappears, is cured. Without that change in relationship, it's impossible to recover from a chronic pain state. So that's what I believe. Through music and theater, somehow we can change the hearts of everyone. And through the audience reviews that I've had, people living with chronic pain, it has been incredible. So it's been a 4-year project so far. And so far, I'm looking for a producer who is willing to fund it because I've spent over $100,000 on this project so far, my own investment. And So far through donations and ticket sales, I've made about $20,000. So you can see it's not a money-making scheme that I'm doing, but it's truly a project of passion because I believe through theater and arts, we can change hearts and minds. If it goes mainstream, wonderful, because I want this show to travel and go everywhere. I know Tiffany got to see it, but you didn't, right? Were you there, Tess?
No, I didn't. I really, really wanted to come. But yeah, flights and then the timing.
Oh, you're not in Toronto.
No, I'm not. Otherwise, I would have come.
What city are you in?
Winnipeg.
I'll come to Winnipeg. There's a Winnipeg theater there. It's just so costly to run a show. It's like $50,000 just to run a workshop.
Yeah, and it's such a passion project for you to build that off the ground and have that running, and then eventually it'd be great if it could tour, because the messages you have in the play are so impactful, but also the medium of theater can change people's hearts and minds via a way that's also entertaining and fun. I was so interested in this play when Tiffany had mentioned it and when I was looking into your works, because I have a background in theater.
Yes.
So I was particularly excited to hear about it. And when I was listening to you and learning about it, I was reminded about how people of ancient Greek society would go to the theater as, you know, as a ritualistic experience, how the stories on stage could have what they called a cathartic effect. That catharsis was described as a purging of emotions. You mentioned a bit about the feedback you've been getting and from perhaps chronic pain patients who've seen the play. Now that you've had some performances, what were those responses like? Can you tell us a bit more about it? And would you say the show had a cathartic effect?
I would say yes, because remember how I said you can't change people by making them read a book or watching a video, right? But one way that you can is by tugging them, hitting them in the emotions. And there's not a dry eye in the audience during this show. So that's intentional because the stories are so real and the actors and performers are incredible, demonstrating their coping skills with chronic pain, whether it's due to grief, a loss of a loved one, or living with arthritis, or living with body dysmorphia, and rejections, and all the things that maintain chronic pain. And it's so emotional. People say, couldn't you turn this into a film? My gut feeling says, no, you can't get that in film. I wanted theater intentionally because I believe when you see that person in front of you, like you say in Greek, if you took a Greek play and put it on video, it would be like, meh. That's why I intentionally don't want videos of my musical to be available online because it just would be meh, wouldn't be anything. I have clips of it on website if you want to see it, painmusical.ca. I have 2 minutes, just people get the gist of it. But it's not about the message. It's about that emotion that it hits when you're seeing it live theater. When something hits you emotionally, that's when you'll connect with it and actually have an impact on you. I have audience reviews on my website also, and people literally, they're not saying it to impress me because I don't know them. They said, this play literally changed my life. And people with opioid addiction say, I wish I'd known the messages in this play years ago. Maybe I would not have started opioids. Because I've read the studies, the highest predictor of people actually taking opioids or becoming dependent on opioid is their relationship with pain. If you're constantly trying to escape pain, then the mindset is pain is evil, I need to escape it. But if you have that switch, when the mindset is pain, I don't need to escape it. I need to understand it and listen to it and be with it and allow it to be at this moment. Then the escape mode goes. Once the escape mode goes, the nervous system calms down. And you don't need opioids to escape it. So if we want to tackle the opioid addiction, I truly believe my musical is one way of doing it. Because trying to get people off of opioids, uphill battle. However, preventing somebody to decide whether when a doctor prescribes it, I will take it or I don't need it. Or even if you take it post-op for a few days, no big deal, because I don't need to escape pain. I learned that from the musical.
And it sounds like for people to go see a musical like this, which is, you know, they're going to the theater, they're not going to a hospital, a pain clinic, a healthcare professional. They're seeing this work of art and they're allowed to take it for what it is and make their own interpretations about it and connect with it however they will connect with it. Perhaps that also opens up the way to approach this information in a way where it's not being forced upon them and nobody's trying to tell them, oh, you should do this or try that. It's just there. Perhaps it's also like a more gentle way to get that information across. And like you mentioned, it can be an uphill battle and communicating about these concepts with people can be very challenging. So I love that you created this art piece and that through theater, and like you mentioned, there's nothing like live theater and the impact it has. And for anybody who's never been to the theater, please go. It's such an amazing experience. And I do believe that catharsis is real. Definitely yours, Bahram. I can't imagine how much impact that must have had. So for the audience to get a better sense of your creative work and your style and a little bit more about the show and what they might hear if they have a chance to see in the future, would you be able to perform a piece from the musical here on the podcast?
I've decided to do a rap song then. The rap of the music, and I may not do it exactly as it is. So excuse me if I stumble through it, but I'll sing over the actor who sang it last year. Because last year, Payne was male for the last 3 shows. And this time, Payne was a female. We made Payne the character female. Both excellent. They're all excellent. And so it's a male voice, this one. I'll try to go over it. So it'll be a little rough at the edges, but I think I'm going to go through with it. Here we go. This song is called Payne Speaks in Me, Dr. J. You want to know why I'm here?
Great! I'll turn off the jokes
and give it to you straight.
I received this body, this flesh, this voice. Yes, I materialized. I had no choice. I had to stand, had to walk, had to talk and be heard. I needed you to see me and hear my every word. Now, from my unique point of view, I can share my side of the story with you. I long to be accepted, not rejected, but respected. But most of all, to be listened to. As your Payne, can you answer for me one simple question? When you think about me, what's your perception? Am I the hero, the real McCoy, or just a villain that you hope to destroy?
I don't wanna hear you, be near you, or fear you in any way. Why must you possess me, distress me, depress me each and every day?
I know sometimes I linger longer than you like, but when you refuse to listen to me, that's when my level spikes. So why do you disdain me? I just don't get it. I help you to survive, and yet I never seem to get the credit.
Tricked, bullied, loathed, betrayed, angry, hostile, bitter, afraid, desperate, detested, deceived, deplored, on edge, frantic, anxious, ignored.
It sounds absurd, but I yearn to be heard.
All right, you received this body, this flesh, this voice, and yes, you materialized. I guess you had no choice. You had to stand, had to walk, had to talk and be heard. So what you gotta say, Mr. Theater of the Absurd?
Okay, why the heck do I always seem to get the blame? Time after time, Payne gets a bad name. Accusations based on a false smear campaign. Hounded, surrounded, confounded, forever blamed. Sure, I might appear after an injury, but how's that my fault? It's just what came to be. I don't deserve all this rancor and hostility, so stop the accusations. I'm not your enemy.
You are not my friend, Payne. Comprehend, Payne. Do not pretend, Payne, and do not reappear. Despite what you proclaim, you do deserve the blame. I wish you never came. Stop returning and returning and returning here.
Chronic pain, people, is a worldwide epidemic. But the problem isn't physical, it's systemic. Persecution, abandonment, and isolation? Do you really think that you can solve this with a medication?
Bullied,
Kill me with a pill?
betrayed, angry, hostile,
You're defeated before you begin.
desperate, detested,
Wage a
deceived,
war against
ignored,
me?
on edge.
The truth is, you'll never ever win. Yes, people want their pain to go away or decrease, but to truly ease their suffering, they have to make the peace with me. The constant struggle to escape the tiring act. The harder it's attempted, the more severe the impact on the spirit. It's fine to blame the reason for your pain, but to blame pain itself? Honestly, I'm not a ball and chain. If I could help you grasp one thing, I would.
All right! What's the one thing you would tell us if you could?
Pain is good.
That was really good. Thank you, Bahram.
Just listening to you and the words, I really wish I could have gone and seen the show, and maybe I should have flown to Toronto, but hopefully you can tour Canada and more people have the chance to see your amazing work and for it to touch many more audiences across the country.
It's my dream. Well, maybe it'll get promoted thanks to Pain Cats. I want to spread the word. If there's somebody knows a music producer, and there's some people who have been interested, but to do like a full production, I need like $300,000.
Yeah, it's a big investment and risk for sure.
Yeah, but it's not about the risk. I want marketing behind it. You need a theater who's willing to say, I believe in this show. And I believe there's somebody out there who will believe in it.
Mm-hmm.
Well, thank you for sharing that piece with us, Bahram. Before we close, I'd love to ask, now that you're finished the musical, what's next for you? Do you have any other projects that are coming up?
I'm actually working on a one-man show right now, meaning where I'll just play pain. Remember I said I love theater and thing, where I want to go to hospitals and clinics like MH and even conferences to play the character pain myself. Not sing, because again, singing, you need a band and you need productions and sound, but just the one-person show and get the message across, but through theater and comedy. So I'm working on that with a playwright right now as we speak, because it's a more feasible thing to go around and tour.
Yeah, it seems such an interesting idea. If you were to go into hospitals and show up as pain, like get that messaging across, it's almost like pain that is traveling to different places around the world, right? It's not something that's in one place. It's something that you go to and people experience it wherever, whatever setting that they're in. It's not necessarily like a theater setting.
Yeah, I want to make sure that it's really entertaining though.
Mm-hmm.
So that's my thing on the works. The musical hasn't ended. I'm still waiting for producers, hopefully production again.
Bahram, would you consider touring as part of the fringe festivals around Canada? Like Edmonton has the biggest one, Winnipeg has the second biggest. Lots of people go and see shows often on a whim, sometimes without even knowing what it's about. And I'm just wondering if that's another way where it could touch more audiences that, they had no idea what they're going to see except that it's called pain. And they go check it out and then they come out of it transformed, perhaps. Just like a thought, I'm curious if that's something you've considered.
Yeah. At first, I'm trying to get it done, and then I'll go that next route. So great idea. But this show is called Pain Speaks. Actually called PS, Pain Speaks.
Oh, cool. Yeah, it's even more catchy. I could see that on a poster.
Yeah.
Yeah, very, very cool.
Pain Speaks. So what is pain speaking about? Again, another way of communicating pain education, but I wanted to really tug people's emotions. These messages are in books and videos already. It's not new. In fact, most of the stuff, my concept is not new. It's been done for thousands of years of having compassion for self and letting go of trying to fix pain. It's Buddhism 101, which is the most influential thing I could say in my practice. More than my physio practice, more than physio school. Because Buddhism philosophy, I say, has influenced me.
Wonderful. Is there anything else you wanted to add?
Sometimes I'm asked, if I could go to school, what would I change? If I could change the curriculum, I would eradicate pain relieving modalities program from universities. The whole concept of relieving pain, I think, is wrong. Mm-hmm. I know we're going to look back one day and say how wrong we were, try to fix pain and eradicate pain. And we're going to say that's the number one cause of chronic pain, our obsession with trying to fix it. Because as physio, that's not how the profession started in the first place. After World War I, we never tried to fix pain. We were trying to get people who lost a limb after amputation from a war injury to walk again. It was function. It was always about getting people's back quality of life. It was never about fixing them. Mm-hmm. We never fixed their C5-6 or L4-5 or mobilized them, or soft tissue release or tingling machines on them. That came about decades later when we obsessed with fixing pain. Our job should only be getting people's quality of life back. I'm technically an OT. I'm completely an OT. I deal with the psychosocial issues and focusing on function. In fact, some of the things that are taught in physio school, I'm ashamed of saying it because I think it's the cause of chronic pain, our obsession with biomechanics.
That is such an interesting approach. And when you talk about changing curriculum, I believe there is some changes coming where there isn't as strong as an emphasis on EPAs. Yes, they're still being taught, but they don't take up as big of a place in the curriculum, and they're definitely taught with an approach that, it's used as an adjunct, perhaps also to meet some of the expectations of patients. And like you had mentioned, where to get them to buy in, like perhaps you have to start off with giving them what they want, giving them what they expect, but then not just leaving the treatment at just that. And still knowing how to use them is a good idea, but not have that be the only intervention, of course. And everything you've taught us and your insights have been so great to hear. And it was such a pleasure talking with you. Thank you for answering all our burning questions that we were so excited to ask you.
Well, thank you, Tess. Thank you, Soheyl. Thank you, Tiffany. Thank you, Paincast.
Thank you for listening to this episode on interacting with patients living with pain and spreading pain knowledge through art to touch more people's lives. Paincast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, and practically oriented content.
To help more people know about this amazing resource, follow us, rate us, and share our content with your network. Follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.